Welcome everybody. I've been charged today to discuss how data and AI has influenced my practice. But after yesterday's talk, I feel like a more appropriate presentation would be how a 30-minute presentation by Dr. Chris Ames destroyed a young surgeon's decision-making rubric and made him question all the philosophies that he based his entire practice off of. So thank you for that. Telomeres, I thought I was getting this, but apparently not. So I'm going to rewind the clock about 24 hours so I don't have to think about all of the questions that his presentations raised for me yesterday, and hopefully you'll find what I say today useful or have some utility in your practice. Here are my disclosures. I'll start this by telling a story. I've told this story to CJ Kleck multiple times. He's probably tired of hearing it, but I was about 1.5 to 2 years into my practice, and I had just sat for my oral boards. I studied a ton, and I knew just enough to be cocky and arrogant at times, but not enough to avoid feeling anxious and insecure pretty much the rest of the time. And I was attending the SRS annual meeting, and there was a breakout session which was a debate about what surgical approaches were best for managing spinal deformities. And representation for posterior approach was Larry Lenke. For anterior-posterior approach was Munish Gupta. And for lateral approach, it was Juan Uribe. And so each one of these surgeons presented a number of cases and their postoperative imaging, and the corrections were all spectacular. And the conclusion of that session was, there's no one right way to address a deformity, and every surgeon should leverage their skill set to correct the deformities they want to treat, which is great, except David Oyoung was sitting in the audience thinking, I'm not sure I can achieve that correction with any of those approaches. So I was frustrated, to say the least, when I left that breakout session and when I left that meeting, and I expressed my sentiments to some of my senior partners, and I got a myriad of different responses. One of them was, well, those guys only show their best x-rays anyway, so you can't feel too bad, which was not helpful at all. It's like how you feel when Greg Poulter shows one of his percutaneous deformity corrections and you just get so annoyed because I don't think I can do that, right? And then another response I got was, well, this skill set takes many years to develop. You need to be patient. But if you've spent even an hour with me, you'll know that patience is not something that I possess in large quantities. So that philosophy was out the window. And I decided at that point, I just needed to get better at surgery. Now, the first thing I decided I needed to do was figure out what my strengths and what my weaknesses were so that I could leverage my strengths and improve my weaknesses. And for that, I needed information or data. And a lot of you are probably familiar with somebody named Peter Drucker, and for those of you who aren't, he's a gentleman who was responsible for the adage, what gets measured gets improved. And to this point, I had used the UNiD ASI platform almost casually. I certainly didn't have sophisticated plans, but I knew that they would measure my preoperative radiographic parameters, they would help me create a plan, help me execute my surgeries, and then track the radiographic outcomes so that I could evaluate my performance. So at that point, I made a concerted effort to plan every single one of my instrumented cases through their platform. And a year later, I had some data. And while it wasn't a lot of data, it was something. And something that Dr. Ames mentioned in his presentation yesterday that I found very interesting, because I say this all the time, is it's not necessarily whether the data is good, it's whether it's the best data available. And for me, for my cohort, this was the best data available. So this platform will tell you how many cases you've done, what type of cases you've done, and at what follow-up time points you have postoperative data. And I decided on a number of spinal pelvic parameters that I wanted to follow, including pelvic incidence, lumbar lordosis mismatch, pelvic tilt, thoracic kyphosis, and SVA. And Now our analysis is much more sophisticated. We're evaluating dozens of spinal pelvic parameters, but at the time, this is what I thought was relevant and therefore have data to show you. And as I stand here now, I fully appreciate the exposed position I'm putting myself in, because again, this is all of my patients. This is my patient-specific cohort, or my specific patient cohort. Nobody else's. And if you haven't been able to do something like this, I encourage everybody to do it, because you'll find that there are procedures you thought you were really good at that you are terrible at. And you'll find that you're really good at certain things that you never expected to be good at. So, after a year, this is what I saw. For PI-LL mismatch, I started at 8.2 degrees, and I improved to 2.5 degrees. So, for all practical purposes, I was doing pretty good. My PI-LL mismatch was 2.5 degrees. But now we realize that PI-LL mismatch isn't always 0. It depends on the patient's morphology. And so a better metric would be to figure out what the discrepancy was between my PI-LL mismatch postoperatively and what I was planning. And what I saw is there was a discrepancy of 5 degrees, which I felt like certainly could be improved. My goal would be to get that under 3 degrees, or the margin of error for a Cobb measurement. For pelvic tilt, the discrepancy between my actual postoperative values and my planned values was 0.1 degrees, which is great. Now, I can't take credit for that. It wasn't anything that I was doing surgically to achieve that. It was the predictive model that we were using in the UNiD platform. That was created with a supervised machine learning methodology, and it was pretty accurate, so I didn't feel like I needed to make any changes in that regard. I also looked at SVA. My SVA improved on average. My average SVA postoperatively was about 3.5 centimeters, and if you look at that closely, only about 50% of the patients were meeting an SVA of less than 50 centimeters, so I definitely thought I could improve there. And the discrepancy between my actual values and my plan was 3 centimeters. So I wanted to narrow that discrepancy, preferably to within 1 centimeter. Thoracic kyphosis was actually pretty accurate. It was within 2 degrees. Again, credit to the predictive model. I decided to take a look at the surgeries I was performing to achieve these corrections, to figure out exactly why I was seeing these discrepancies in my PI-LL mismatch and my SVA. That included interbody fusions, posterior column osteotomies, and pedicle subtraction osteotomies. So when I looked at interbody fusions, what I found is that I tended to favor T-lifts. I did about 50% more T-lifts than I would A-lifts or laterals. And on average for my interbody fusions, I was getting about 3 degrees of correction per level if I didn't perform some sort of posterior column osteotomy, which is pretty good. It was reliable. When I compared my actual values to my to my planned values, the discrepancy was only about 0.4 degrees, so it was fairly accurate and reliable. But this didn't tell the full story. If I looked at specific surgeries, including T-lifts, I was very reliable, planning about 2.7 degrees of correction per level without a posterior column osteotomy, and achieving that, but I was terrible at A-lifts, which I thought I was good at. And it wasn't A-lifts at L3-4 or L4-5 where I was having issues. It was A-lifts at L5-S1 in particular that I was having problems with. In fact, a lot of times I was losing 5 degrees of lordosis at that level. So I did a critical evaluation of why that might be the case, and I identified a number of factors. One was I was doing a poor job evaluating the pre-existing interbody lordosis. And in terms of the implant I was using implants with limited lordotic options, so sometimes I didn't have an implant that would account for the pre-existing interbody lordosis and then add additional lordosis to achieve a correction. And the final reason was that the particular implant I was using utilized integrated anterior instrumentation with divergent screws both proximally and distally. It was a very rigid construct, and when I placed that instrumentation, if I tried to achieve any more correction posteriorly, it was impossible. In fact, I had a failure with a bone fractured because there was so much restriction or constraint anteriorly. So this compelled me to make my first change. I became hypervigilant about how much lordosis was in that disc space preoperatively. I changed to an implant with more lordotic options, and in cases where I felt like I wasn't achieving the lordosis I wanted with the anterior approach, I instrumented only proximally or only distally so that I could gain more lordosis with posterior instrumentation. So that was the first change I made. O-lifts I was doing pretty good, about 3 degrees of correction per level, although there was very limited data. I didn't feel compelled to make any changes based on this limited data. When I looked at my posterior column osteotomies, I found that on average I was planning about 8 degrees of correction, but really only achieving about 4.5 degrees, which suggested a couple things for me when I evaluated this, and that was number one, maybe I was not evaluating the segments at which I was planning to do the posterior column osteotomies well enough for their mobility preoperatively. I wasn't looking at the disc height. I wasn't looking on FlexX films or comparing their supine films to their upright films to see if they would actually move. I also felt like maybe I could be more aggressive with my facetectomies and resection of posterior ligamentous structures to optimize how much correction I was getting. And I felt like maybe my planning was too aggressive. I was expecting more correction than I could actually achieve. So I changed some things in how I approached that surgery. I became more aggressive with my bony resection, more aggressive with my ligamentous resection, and I started planning 6 degrees of correction instead of 8 degrees of correction, all for the sake of producing reliable correction. Not so much the greatest correction, but the most reliable correction. I had some data on my pedicle subtraction osteotomies. At that point, I was doing most of these as a co-surgeon with my senior partners as the primary surgeon, so I didn't have enough data to say whether or not I was good at this. The very few cases that I had looked okay, but certainly wasn't going to change my technique based on that. So at this point, what was working well? Well, T-lifts were working well. For me, I was getting reliable correction. Maybe not the most correction per level, but reliable. So I felt like I needed to leverage this. Maybe I should become more aggressive with how I do this, how much correction I expect to get from a T-lift. And in fact, I decided to implement the use of an expandable cage to see if I could get even more correction than I was getting. O-lifts were good. I never really liked the surgery, but I would do them occasionally. And the predictive models were working really well, so I didn't think I needed to change that at all. I would continue using that in all of my plans. And then the jury was still out as to whether or not I was good at pedicle subtraction osteotomies. As far as what needed improvement, certainly I needed to improve my ability to achieve correction or reliably achieve correction with my A-lifts, particularly at the L5-S1 level, and I implemented the changes we discussed. My posterior column osteotomies were also not great. I felt like I could improve this because I was doing them frequently. So I did a better job evaluating the flexibility of those levels where I planned to do the osteotomies, and I became less aggressive in my plans, meaning I attenuated my expectation for how much correction I was going to get intraoperatively. And I felt like these changes were going to result in an improved discrepancy in my PIL mismatch or make it more reliable, as well as for my SVA. Again, my goal would be getting my PIL mismatch discrepancy to within 3 degrees or less and my SVA to within 1 centimeter of my plan. So we started collecting data again, and for the next 16 months or so, I did more cases planning this way. And what we found is that for my interbody fusions, I actually got slightly worse. I was getting slightly under 3 degrees of correction, but I was planning almost 5 degrees of correction. And if you recall, before I was getting 3 degrees of correction, but planning 3 degrees of correction. So I got a little bit worse, not significantly, but I got worse. But the main problem was that my expectations were so high in my surgeries that I was far less reliable than I used to be. And it wasn't in A-lifts. I actually got better with A-lifts. That became reliable. O-lifts remained reliable. It was my T-lifts because I had such high expectations in terms of how much correction I can get with the T-lift, 5 degrees I was planning, that I couldn't possibly achieve that with the technique that I was doing. So I decided to go back to planning 3 degrees of correction per T-lift, and we'll have to wait a year to see how that turns out. For posterior column osteotomies, what I found is that by limiting how much lordosis correction I was planning to 6 degrees, becoming more aggressive with my facetectomies, and evaluating the mobility of the segments preoperatively, I became very reliable in achieving the correction that I wanted. I planned 6 degrees, I get 6 degrees. Now this is a strength and something that I leverage when I do my deformity correction surgeries. In fact, if I'm afraid with an interbody fusion that I won't get the correction that I need, I just add a posterior column osteotomy because that is reliable for me. I also had some data for PSOs, not a lot, but some data. And this suggests that I plan 22 degrees of correction and I get 22 degrees of correction and I'm reliably able to do so. So this is something that I also leverage if I have a deformity that I'm trying to correct. So what did this amount to? Well, from a PILL mismatch standpoint, my mismatch on average is now 0.8 degrees, which seems good, but it's the discrepancy, again, that I'm worried about the most, and that is 3 degrees. So that's an incremental improvement from previous, where the discrepancy was 5 degrees. And while it's only a small change, I do think that these things add up. My pelvic tilt remains accurate, thoracic kyphosis remains accurate. In fact, the discrepancy between the actual and predicted thoracic kyphosis is 1.6 degrees, so I'm not planning to change how I approach that. In regards to my SVA average is now 3 centimeters, which still bothers me a little bit, but the discrepancy between my plan and actual value is now 2 centimeters, which is a centimeter better than before. But that's not the full story. There are some cases where we can't perform the UNiD plan, either because we're unable to place instrumentation intraoperatively, or the rods couldn't be made in time, or, for example, a couple weeks ago, we planned an L5 PSO, and just before the surgery, we realized this patient had transitional anatomy with bilateral pseudoarticulation, so we elected to perform an L4 PSO rather than L5 PSO, so we changed the plan slightly. So when I looked at patients where we were strict about the UNiD plan, the discrepancy between my planned and actual SVA was actually only 14 millimeters, or 1.4 centimeters, which is twice as good as where I was previously. Again, an incremental change, but I think these things add up. So what's working well at this point? O-lifts, A-lifts, reliable. The predictive models, reliable. Posterior column osteotomies, very reliable, and PSOs, reliable. These are the strengths that I leverage when I do a deformity correction currently. What's not working well? Well, I'm back to the drawing board with T-lifts. I've stopped using that particular implant. I've stopped being so aggressive in my planning. I'm back to 3 degrees of correction in my plans. And if I need more, I plan to do a posterior column osteotomy. And while I think that will lead to incremental improvement in my PI-LL mismatch and my SVA and some of the other spinal pelvic parameters that we're now measuring, I wasn't confident that that was the primary reasons why I was still having these discrepancies. So I looked at an area of the spine where I hadn't looked before, and that was the thoracolumbar junction in my long construct fusions. And what I found is that, on average, I was planning about 4.5 degrees of correction, but achieving 0 degrees of correction. In fact, it's worse in some cases. And again, when I did a critical analysis of this, I determined a couple things. I was poor at evaluating the mobility at that segment, or those segments. And the other thing that I found is that the contour of the rod occasionally did not match the sagittal cob angle that I was measuring at the junction. So I've since asked them to change the morphology of the rods to better match the cob angle at that junction. And incidentally, if you do a simple arc calculation from C7 to the thoracolumbar junction and a chord calculation there, a 4.5 degree correction at the thoracolumbar junction amounts to approximately 2 centimeter improvement in SVA, which is my discrepancy. So those are the changes I've made. Again, we'll have to wait a year until we know whether that worked or not, but I'm optimistic that I'll be very close or have surpassed my goals at that point. I'd be remiss if I didn't mention that this talk focused primarily on radiographic outcome metrics, but this platform also records patient-reported outcome metrics at this point, and in this case, PJK. Of the 66 long construct fusions that I've done, they've been able to tell me that my PJK rate using a metric of greater than 10 degrees is 12%, and over 20 degrees is 4%, which to me is pretty good based on the current literature, something I don't plan to worry about too much for the time being. So a platform that allows you to plan, helps you execute your surgery, collect data and analyze your data, allows you to implement changes that can result in incremental improvement in multiple areas of your practice that culminate in significant improvement in your surgical abilities. I realize now that from a deformity standpoint, I may never be as good as Larry Lenke doing VCRs. I may never be as good as Munish Gupta doing A-lifts or Juan Uribe doing X-lifts with ACRs, but with advanced data analysis, I don't have to be. So this was supposed to be a case. It's really, we're out of time. I'd like to thank our UNiD team for collecting all this data and dealing with all of my idiosyncrasies and then putting some of this stuff together. And then obviously my colleagues at the University of Colorado and Medtronic. Thank you.